I invite Professor Vijayaraghavan sir from Coimbatore to talk about optic neuritis.
Good evening. Thank Dr. DC for this great opportunity. Are there any PGs are here? I do not know whether PGs are not. All are PGs. Don't worry. Okay. See, optic nerve is not a nerve. Please remember that. It's only a wide fiber tract connecting second order ganglion cells and the neural axons going up to the LGB. LGB is a third order neuron in the visual systems. That's why it is not a nerve. It's only a wide fiber tract. And moreover, it has got no neural lemma. That's why when you have an injury, it will not regenerate. Unlike in the case of third nerve, fifth, seventh nerve and all, you got aberrant regenerations, which can never occur in optic nerve. That's the reason if it gets damaged, you cannot recover the vision. That's the most important point. Then we have got isolated. What is isolated optic neuritis? Inflammation of optic nerve again. But when you are not having associated multiple sclerosis, when you are not having any other problems associated, systemic problem associated, you take it as isolated. But you cannot leave it like that isolated because this fellow may land up in multiple sclerosis in future. That's why you have to follow the persons properly. That's why I told you, optic neuritis, whenever a patient comes to you, always follow him forever. The reason is he may develop multiple sclerosis, so many complications in future. There's the importance of optic neuritis. We are going, because the patient will come to us only with the visual loss. We are diagnosing, but don't leave the patient. At least tell him to follow up, or at least let him go to neurologist for further evaluations. Based on topography, normally we tell what now, optic neuritis, axial neuritis, mainly the macular fibers are involved. There's you got a central scotoma. But central scotoma is one of the most common problem as a clinical or a field defects you can expect in optic neuritis. But never forget, it's not the only thing. We can have even contraction of fields because periaxial or peripheral fibers are involved. Or I can have a transverse neuritis also may develop. That's why central scotoma is not the only feature for optic neuritis. You can have any type of field defects, you can get it. That's the reason for this, because of topographical involvement. Ophthalmoscopically, you see disc is involved, papillitis. Okay, irritable neuritis, that means patient sees nothing, you are also not seeing nothing. That's called irritable neuritis. Whereas one neuroretinitis is there. Neuroretinitis, we can have hard X-rays in the maxilla and all associated with papillitis. We call it as neuroretinitis. Now, etiology. I'll tell you most important point. The most common cause for optic neuritis or irritable neuritis is demyelinations, multiple sclerosis. My advice is that sometimes for postgraduates, they will ask you questions. What's the most common cause for neuroretinitis? Never tell multiple sclerosis because we do not have myelin sheath in the retina. That's why we will never get neuroretinitis in multiple sclerosis. It's a normal person. I can have myelin sheath abnormally, that's different. But myelin sheath in the retina is absent. That's why neuroretinitis cannot occur because of demyelinating problems. It's the most classical exam question for you. Then we have got para-infectious. What is para-infectious? That means I got vaccination to the patient. Patient develops neuritis. That's called para-infectious. Infectious, we have got tuberculosis, syphilis, so many infections are there, viral infections, so many things are there. They are all coming and be infectious. Whereas non-infectious, classically you should know something about sarcoidosis. Sarcoidosis, of course, rare in our country. In our country, it's rare. But normally we may be missing the problem also. We think as if it's a case of tuberculosis. That's why we may be missing the problems, but usually non-infection means sarcoidosis. I told you. Para-infectious, I told about following vaccinations. These are also okay. Infections, I told you, bacteria and all these things. Here, always remember, one thing, common question is what? Sinus related. We will ask in exams for postgraduates, which sinus is notorious to produce optic neuritis? Our answer should be sphenoidal sinus. Because sphenoidal sinus is in close relation to optic canal. That you say only thin bone is there. So naturally a sphenoidal infection can involve optic nerve. That's why optic neuritis, commonest source of infection, just which sinus means answer should be sphenoidal sinus. That is called what is called as Van der Hoef sign. That's called as Van der Hoef sign. Sphenoidal sinusitis involving optic neuritis, developing signs and symptoms of optic neuritis called Van der Hoef sign. Van der Hoef. Just remember some of the things. Other things we like syphilis, Lyme disease. We have got Borrelia burgdorferi. So many infections are there. Then cat scratch. That's called Bartonella. These are all some of the bacteria a PG is supposed to know. Sarcoid. If you are asked the classical exam questions, what? The disc appearance. Lumpy and bumpy. Lumpy and bumpy disc. You can have granular mass in the disc. You can have, that's called lumpy and bumpy disc in the case of sarcoid. But one more question will ask you, which is the other condition where you can have a lumpy, bumpy disc? Your answer should be drusen of the optic nerve head. Drusen. Neuroretinitis, I already told you, never tell. Your answer is demyelinating problem, cannot, should not tell. Whereas other conditions like cat scratch, Lyme disease, mumps, these things can produce neuroretinitis. Never forget that. Now, classical what? Patient comes to with demyelinating problems, usually unilateral. Unlike papilledema, may be bilateral. Whereas here, female sex more common between 20 and 40 years. Very rarely, I'll tell you, very rarely, optic nerve, you will have visual loss problem, visual reduction may be there. But very rarely, you can have a 6-6 visual vision, that's called 6-6 optic neuritis. That can happen where? Only when the maxilla fibers escape. That axial portion is not involved. You can have a 6-6. That is called 6/6 optic neuritis. Just know this. That's called 6-6. What are the symptoms? Loss of vision, of course. Loss of vision is there. Pain on movements. Elevation and adduction is a classical exam question again for PGs. On elevation and adduction, patient will experience pain. The reason is, so superior rectus and middle rectus tendons have got attachment to the dura mater of the optic nerve at its origin. The optic nerve is inflamed. So when these muscles contract, they can pull the optic nerve. Naturally, they can experience pain. That is called as Whitnall hypothesis. It's called as Whitnall hypothesis. Without sign, that means when you increase the body temperature of the patient, demyelinating problem is there, optic neuritis is there, multiple sclerosis, you increase the body temperature, the vision may be coming down again. Suppose my vision is 624, it will come to 660. The reason is, see now there are so many reasons for Uthoff's phenomenon. When you have a problem of increasing body temperature, we produce some chemical substances in the demyelinating areas, which can inhibit the further message. Whereas one more thing is that, we have got demyelinating plaques are there. The plaques around the optic nerve, when they increase the body temperature, doing exercise and all, they can become edematous. When they become edematous, they can compress the axons. So further problem can occur. That's the reason. Uthoff's sign is because of edematous plaques compressing the optic nerve, which can occur in a patient with a demyelinating multiple sclerosis. It's called Uthoff's sign. One more important point I'll tell you. Suppose you are having optic neuritis case. Okay, normal demyelinating problem is there. Normal circumstance. Within 2 or 3 weeks, you should improve. If it is not improving, the vision is not coming down. It's normal circumstance, I'll tell you. It has to improve. If it is not improving, that means it's not the case. You are dealing with something else. Maybe you are dealing with some compressive lesion. We do not know. That's why always remember, a first time optic neuritis patient you are diagnosing, it should come down or it should become normal at least within 2 or 3 weeks. If not, be careful. That's all. This is what normal now conductions. You see now myelin sheath is absent. You can see the conduction getting delayed. Can you see these delayed conductions? This is what's happening in optic neuritis. Signs, visual acuity reduced, I told you. Pupil RAPD is there. Know that. RAPD is the relative apparent pupil defect. Can you see now here the right eye pupil constricts and you put the light in the left eye pupil dilating. Now come back to right is constricting. It's called left eye has got RAPD. Never forget this. Left eye has got the most common cause for RAPD is optic neuritis. But we have got so many problems in the retinal movement, CR occlusion, vein occlusion, so many things can happen. RAPD can be there. One important question for postgraduates. Whenever you have got, suppose in this case left eye optic RAPD is there, never forget to tell in the exam, suppose you are asked, optic tract in the other side. Always remember, optic tract is involved means opposite eye will show RAPD because the nasal retina is going there. Your nasal retina is excess. Nasal retina is very important for our pupillary reactions. That is why nasal retina in the left eye is crossing into right tract. So the right tract is involved, I can have a left RAPD. Always tract involvement will produce contralateral RAPD. This is what common exam questions again. Full feature, of course. Color vision, contrast, everything is there. Problem patient can have optic neuritis. But now the field changes. The central scotoma is there. The question is what? We will ask in exam. In Humphrey field analyzer, when you have a central scotoma, how do you proceed? Because the fellow cannot see the light in the center. How do you proceed for the testing? Because patient cannot fix the target. Your answer is, sir, I'm having a diamond target. Large diamond is there. You ask him to fix inside the diamond. I can proceed. This is a very question. Suppose you say the chart, Humphrey chart, you see the fixation target, diamond. That means he's having central scotoma, he's having optic neuritis case. Or a central scotoma is there. That's all. Very simple to see from the chart itself. Okay. Of course, Jerem screen all we are not using nowadays. So no problem. Understand now? I told you already fixation target. Whenever you have a children problem, bilateral optic neuritis means always you are dealing with the infections. Never forget that. Slit lamp, you have to see for cells in the vitreous. Then fundus, of course, hemorrhage and exudation near the optic disc may be there in a case of optic neuritis. AION, already Dr. Saravanan told about temporal pallor and all, maybe there in AION. Understand now? This is what disc is hyperemic, margins are similar to a papilledema only. Never forget that. Maybe the problem is what now? We can have visual losses. Papilledema patient may not have visual loss, that's all, usually, unless he develops optic atrophy. Otherwise, optic neuritis patient will have visual loss, whereas papilledema no. Papilledema are usually bilateral, optic neuritis usually unilateral. Never. These are some of the differences they will ask you. And papilledema can have enlargement of blind spot. Optic neuritis can have central scotomas, like that field effects. These are some of the, and RAPD is that people, whereas papilledema people may be normal, unless a problem occurs in late stages. Understand now? These are some of the differences we'll ask in exams. And never forget to rule out different compressive lesions. I'll tell you one important point. Suppose I'm having optic neuritis, like some optic nerve problem is there. You think RAPD is there. Understand now? But the problem is what? I can have a post-fixed chiasma. Post-fixed chiasma is there. Post-fixed, that means pituitary enlarging. It can come as optic nerve. They can develop optic nerve problem because the chiasma is moved backwards. A long optic nerve is there. It can compress the optic nerve. It can produce problem for the patient. That's why whenever you say optic nerve problem or something, visual acuity problem is there, you think optic neuritis is there, something optic nerve is involvement, never forget to ask for MRA so that you can see the pituitary lesions. Otherwise, you will be missing the pituitary lesion. Understand now? That's why the most important point. Why do you want to investigate? Rule of the compressive lesion, main aspect. See, everyone knows multiple sclerosis, they can all treat. But the most important point, you have to rule out a compressive lesion so that you can life-saving problems. CT scan, MRI, the most important things. Understand now? Other things like other investigation. Suppose syphilis means I have to do some investigation. Tuberculosis, you have to do some investigation. Like this. X-ray just means you have to rule out for some sarcoid and all. That's some of the investigation you're supposed to. But never forget the CT scan, MRI to rule out what? Some brain tumors or something. Of course, nowadays they have been told now HLA-BT101. This fellow, key female fellow, if they are having this, they are notorious to develop multiple sclerosis in future. HLA-BT101. These are some of the studies concerned with optic neuritis to get the treatment. That means mainly for the multiple sclerosis. All of you, the PG should know this. CHAMPS means controlled high risk AVANX. AVANX means interferon beta 1A, multiple sclerosis prevention study. ETOMS means early treatment of multiple sclerosis study. Here also they were using interferon beta 1A only. It's called AVANX. Champions means ongoing neurological surveillance. I have given AVANX treatment. I want to follow him further. What's happening with the patient? I'm going to take a MRA, keep on doing MRI, like that, keep on following the person, whether the fellow develops multiple sclerosis or not. That's called champions. Benefit means interferon beta 1B. That's called beta seron in newly emerging multiple sclerosis. Benefit. These are some of the names. Just know this. These are some of the studies they have gone undertaken along about the optic role of interferons in the management of optic neuritis to prevent multiple sclerosis or not. Okay, that's why what's the idea I already told you. Optic neuritis patient comes to us first, you investigate, you find out the problem. He may develop in future multiple sclerosis, so that accordingly you can refer the patient so that you can save the patient from dreaded life. Understand now? Thank you very much.
Thank you, Dr. Vijayaraghavan, for that wonderful